Hi everyone, I'm Dr. Sravya. Today I'm here to give an overview on the vesicular bullous lesions. The speciality of this topic is probably it has given nightmares for all of us during the undergraduation and for me even during the post-graduation time. Main objective of this lecture is to simplify this complexity and make it easier to remember. Please do watch the video till the end to get a clear view about this topic. My lecture goes under the following headings. Introduction. It is important to know the basic concepts to understand the difference between the healthy and diseased. So, I start with basics, that is epithelium and its junctions. Basic terminologies that come across the discussion, followed by the classification of the vesiculobullous lesions. Since the topic is very vast and because of the time constraint, I can't cover all the lesions in detail. So, I have chosen Pemphigus and the Pemphigoid lesions, how to approach the diagnosis, the approach to MCQ questions, and finally the conclusion. Moving on to the topic, the term dermatology means the study of skin diseases. This branch deals with the lesions that primarily affect the skin and also the systemic diseases showing the cutaneous manifestations. Being a dentist, why are we concerned about these skin diseases? Because along with the involvement of the skin, they also involve the mucous membrane, that is oral cavity, and the lesions occur much prior in the oral cavity before the involvement of skin, and sometimes the oral lesions are more prominent and helps in easy diagnosis. So the dentist should be in a better position to diagnose these conditions much early before the involvement of the skin. Dermatosis is the general term used for skin lesions. These dermatoses are categorized into four groups. A group of lesions which has hereditary or genetic onset are grouped under genodermatoses, and a few genodermatoses has alterations in the keratinization process. So they are grouped under genokeratosis, and then we have vesiculobullous lesions and erosive or ulcerative lesions. So today we are discussing about the vesiculobullous lesions. A group of lesions characterized by formation of vesicle and bulla clinically are grouped under these vesiculobullous lesions. So these lesions develop vesicles and the bulla, which often rupture and result in formation of the erosions and ulcers. So these lesions involve both the skin and also the mucous membrane like oral mucosa, genital mucosa, etc. And most of these vesiculobullous lesions are immune mediated, and pathologic mechanism of these involve the autoantibodies binding to the adhesive cell junctions. In order to understand these concepts better, I'll throw some light on the layers of epithelium and the cell junctions. The moist mucous membrane lining the oral cavity is known as oral mucous membrane or oral mucosa, and it has two major components, that is epithelium, underlying connective tissue stroma or lamina propria, and interface between them is the basement membrane. The type of epithelium in the oral cavity is the stratified squamous epithelium, and it has two major characteristics, that is the cells are tightly attached to each other and they are arranged in different distinct layers or strata. So this occurs due to the proliferation and differentiation of the cells. For example, this is the basal cell and this undergoes mitosis and produces two daughter cells. Among them, the one cell retains the mother characteristics and retain the stemness. The other cell becomes the transient amplification cell, which undergoes further maturation and proliferation as it proceeds further. The oral cavity is formed by three types of mucosa, among them the masticatory mucosa and lining mucosa. So the masticatory mucosa is the one which is formed by the keratinized epithelium, and the lining mucosa is formed by non-keratinized epithelium. So the stratification differs in both keratinized and non-keratinized. In keratinized, we have stratum basale, stratum spinosum, stratum granulosum, and stratum corneum. Whereas in non-keratinized, we have stratum basale, spinosum, stratum intermedium, and stratum superficial. Parabasal or suprabasal layer of cells is nothing but above the basal layer, the first two layers, or the deepermost two layers of the stratum spinosum forms the parabasal or suprabasal cells, which can undergo proliferation like the basal layer. Like how human body has skeleton for its support, the same way each cell has its own cytoskeleton which helps in the formation of structural framework. It facilitates the intracellular transport, it helps in formation of cell junctions, and even helps in motility of the cell. Based on the size, the components of the cytoskeleton are categorized as microfilaments, intermediate filaments, and finally microtubules. So microfilaments are actin filaments and intermediate filaments are cytokeratins. So both of them play an important role in the formation of the cell junctions. So here comes the intercellular junctions, one of the most important topic in oral pathology and frequently asked questions in the exam. So junctional complexes are the structures which help in holding the cells together, and these specialized structures are of three types. So one is the occluding or tight junctions, adhesive junctions, and the communicating junctions. So if we see in this image, coming from apical to the basal region, so this direction, so the first common region is your tight junction, followed by your adhesive cell to cell junctions, and then you have your gap or communicating junction, and finally the basal most area we have hemidesmosome, which is also an adhesive junction between the cell and underlying connective tissue stroma. Okay, so coming to this tight junction or zonular occludence, as the name suggests, this helps in attaching the cells tightly, forming an impermeable layer and prevent the leakage of the materials through them. So this is zonular occludence. Zonula means it covers an entire circumference of the cell. So if we view in three-dimensional, so this is how the tight junction appears. And then we have the zonular adherence. So this zonular adherence, zonula means entire cell, as I said. So this is present below the tight junction, and below this zonular adherence we have the desmosomes or macular adherence. So macular adherence, macula means it is a localized one. So this does not cover entire cell. So the junction is present only in this location. And then coming to your gap junction. So this gap junction helps in the movement of the ions and signaling molecules between the cells. So this is nothing but the communicating junction. And the last and important most is your hemidesmosome, which is an adhesive junction which connects the cell and underlying connective tissue stroma. Okay, so we have here desmosome and hemidesmosome. Understanding of these two is very important to know the formation of vesiculobullous lesions in a better way. And then these intercellular junctions are formed by three major components. So that is your transmembrane adhesive proteins, the cytoplasmic adapter proteins, and your cytoskeletal filaments. So imagine this is your cell and this is your cell membrane. So in the same way we have an adjacent cell and adjacent cell membrane. So as the name suggests, transmembrane adhesive proteins. So these are the proteins which are present across the cell. So this is your transmembrane protein. So some part of it is present inside the cell membrane and the other part in your intercellular space. So this is your intercellular space. In order to form a junction, we need the adjacent transmembrane adhesive protein. So the outer portion of the transmembrane adhesive protein joins the opposite transmembrane adhesive protein and results in formation of a junction. So in order to stabilize this, we need the support from internal aspect of the cell, that is your cytoskeletal filaments. So in order to join these, we have the cytoplasmic adapter proteins. So these cytoplasmic adapter proteins helps. So this is your cytoplasmic adapter proteins. So this cytoplasmic adapter protein helps in joining your transmembrane proteins with your internal cytoskeletal filaments. So thus we have our transmembrane proteins, we have our cytoplasmic adapter proteins and the cytoskeletal filaments combine together and result in formation of an intercellular junction. Moving on to the desmosomal components, like every intercellular junction, even this has the three major components. So this is your cell showing the desmosome. So this desmosome on a higher power appears like this. So this is your intercellular space, and these are your transmembrane proteins. So the transmembrane proteins of your desmosome are desmoglein and your desmocolin. So that is your desmoglein and your desmocolin. Very, very important, and you have to remember. Then you have an attachment plaque where the cytoplasmic adapter proteins are present. So the cytoplasmic adapter proteins of your desmosomes are the desmoplakin, and then you have the placoglobulin. Okay, desmoplakin and placoglobulin. So these cytoskeletal adapter protein helps in joining these transmembrane proteins with the cytoskeletal component, that is your cytokeratin. The name keratinocyte for an epithelium is derived because of presence of these cytokeratins, and these cytokeratins generally differ in each strata. For example, cytokeratin in basal stratum basal is cytokeratin 5 and 14, which is replaced by the cytokeratins 1 and 10 in your stratum spinosum. Okay, so here these cytokeratins attach to the attachment plaque in a very peculiar manner. So imagine this is one of your cytokeratin filament which is going inside the plaque and coming out in a hairpin bend. So this helps in bearing the shearing forces of your cell. Okay. Let us discuss about the hemidesmosome now. Under the light microscopy, basement membrane appears as a thin line which separates the epithelium from the underlying connective tissue stroma. But under electron microscopy, this basement membrane is not just a single line but formed by many layers. So imagine this is your electron microscopic view of the basement membrane, which is formed by the basal lamina plus the reticular lamina, and basal lamina in turn formed by the clear zone, that is lamina lucida, and the denser zone, that is lamina densa. So basement membrane is equal to basal lamina plus reticular lamina in turn. In basement membrane is equal to lamina lucida plus lamina densa plus reticular lamina. Now coming to hemidesmosomes. So this hemidesmosome is actually known as half desmosome because the integral component of the hemidesmosome represents like a desmosome. So like how desmosome has three components, even here they have three components, that is the cytoskeletal filament, which is nothing but keratin and actin, the attachment plaque containing cytoplasmic adapter proteins, that is placoglobulin, plectin, bullous pemphigoid antigen 230, and transmembrane proteins, that is nothing but integrin and bullous pemphigoid antigen. The differences are, in desmosome, the cytoskeletal filament form a hairpin bend, but in hemidesmosome, the does not form. The cytoskeletal filament directly goes and attaches to the attachment plaque without a hairpin loop, and so this does not bear a shearing forces. And then the other difference is, in desmosome, the transmembrane protein is attached to another transmembrane protein and resulting in formation of the junction, whereas in hemidesmosome, this transmembrane protein attaches with the components of lamina lucida, that is nothing but the laminin. To have a clear view, the transmembrane proteins of desmosomes are desmoglein and desmocolin, whereas the transmembrane proteins in hemidesmosomes are integrin and bullous pemphigoid antigen. Very, very important to remember because these are the components which are repeated again while discussing the pathophysiology of these vesiculobullous lesions. So anytime desmoglein means you should remember it is a transmembrane protein of desmosome, and bullous and pemphigoid antigen you should remember it is transmembrane protein of hemidesmosomes. Then the cytoplasmic adapter proteins of desmosomes are desmoplakin and placoglobulin, whereas hemidesmosomes it is placoglobulin, plectin and bullous pemphigoid antigen 230. Then the components of lamina lucida is laminin. The lamina densa is formed by collagen 4 which is coated with heparin sulfate, and the reticular lamina is formed by collagen 3 and collagen 7. So let me explain the same thing in the picture. So this is your epithelium. This is your epithelium and the underlying basement membrane. Okay. So this epithelium, this is your cytoskeletal filament which is keratin filaments, and then you have the cytoplasmic adapter proteins that is plectin and bullous pemphigoid antigen 230 which connects the cytoskeletal filament with the underlying transmembrane proteins. So then we have the transmembrane proteins that is your integrin and bullous pemphigoid antigen 180. So this bullous pemphigoid antigen 180 and integrin combine with the components of the lamina lucida that is laminin. And finally all these join together result in formation of an intercellular junction that is hemidesmosome, which helps in connecting the cell with underlying connective tissue stroma. Now let us know about the common terminologies used in this lecture. So macule, it is a well circumscribed flat lesion which is differentiated from the surrounding skin by its color change. So this can be of any color, but commonly it appears as reddish, blackish or brownish in color. So papule is a raised lesion which is less than or equal to 5 millimeters, and plaque is also a raised lesion, but it has a flat top. That means if we see from the far, this lesion generally appears like a flat lesion, but actually it is a raised lesion. So this can be of any size and it generally appears either smooth, irregular or fissured. So vesicle and bulla are nothing but raised fluid filled lesions. So if it is less than 5 millimeters, this is known as vesicle. If it is greater than 5 millimeters, it is known as bulla. Sometimes the vesicles coalesce and result in formation of bulla. Both vesicle and bulla together are known as blisters. Erosion is loss of superficial layers of the epithelium, and clinically this appears erythematous. And atrophy is thinning of the epithelium, rather loss of epithelium. So even this clinically appears erythematous. So ulcer is formed due to discontinuity or breakage in continuation of the epithelium, and this ulcer can be either superficial or a deeper. So if we compare the erosion and ulcer, so erosion is always loss of superficial layers, whereas the epithelium is still continuous, whereas the ulcer is complete breakage in the continuity of the epithelium. Coming to the microscopic terminologies, the term acanthosis is used to describe increased number of cells in the spinous layer. In other words, hyperplasia of spinous layer is known as acanthosis. In the process of keratinization, the basal cell undergoes the sequential differentiation and finally forms a keratinized cell. So any abnormalities in this process leads to formation of a keratinized cell in any part of the epithelium, whether it could be stratum basale or stratum spinosum or stratum granulosum. So the process of abnormal keratinization of either an individual cell or group of cells is known as Dyskeratosis. While preparing the histological sections, the tissue is subjected to many chemical treatments which cause the shrinkage of the desmosomes present around the cell. So this gives the appearance of the spikes projecting around the cell. So because of this appearance, so the layer of cells, this layer of cells is termed as the prickle cell layer or the spinous layer. So this is the normal epithelium of a showing the spinous cells. So the cells are very tightly attached with each other because of the intercellular junctions. But In certain pathologies, there will be disruption of these desmosomes or intercellular junctions, resulting in loss of cohesion between the cells. So in order to describe this loss of cohesion, we use the term acantholysis. So here in this normal epithelium, the desmosomes or intercellular junctions are placed very evenly. But here, if we observe in between these desmosomes, we can see small gaps which has formed. So this is nothing but the intercellular edema. So the development of intercellular edema in between the cells is known as spongiosis. Now moving on to the actual topic of vesicular bullous lesions. So these lesions are classified into various groups based on many things. So first, based on the onset of symptoms, these are classified as acute diseases or chronic diseases. So acute diseases include the viral group of diseases which form blisters and erythema multiforme, whereas chronic diseases are generally associated with the autoimmune diseases or hereditary diseases. So the second classification is based on etiology. So various factors result in formation of these vesiculobullous lesions starting from a normal trauma. For example, the even heat or burn result in formation of blisters. So followed by viral diseases, autoimmunological diseases and genetic or hereditary diseases. So today we are discussing the autoimmune diseases which cause the formation of vesicles or bulla in the oral cavity and also the cutaneous lesions. One more important classification which is required for understanding the vesiculobullous lesions better is based on the anatomic plane of involvement. So according to this, the vesiculobullous lesions are categorized as intraepithelial lesions and subepithelial lesions. So these intraepithelial lesions are further classified according to the level at which the blister formation occurs. So they are categorized into four groups. One is involvement of basal layer, suprabasal, spinous and granular. So again, the subepithelial lesions are again further classified. We have discussed that basement membrane is formed by different layers like lamina lucida and lamina densa. So the lesions which affect the lamina lucida fall into this category, and lesions which further affect the layer below the lamina lucida, that is lamina densa, fall into this category. So I'll explain this classification in detail when we are discussing the pemphigus lesions. Now let us know about pemphigus and pemphigoid lesions, and I'll talk about what these conditions are. How can we distinguish them? Some of the similarities and dissimilarities between them. So let's start. Pemphigus is the word derived from a Greek word named pemphix, which means blister or bubble formation, and this is coined by Wichmann in 1791. So pemphigus involves a group of lesions characterized by chronic autoimmune blistering disorders involving both skin and the mucous membrane. So these blistering disorders are classified by Lever into the true pemphigus and the pemphigoid. So true pemphigus are the lesions which involves the blister formation intraepithelially, whereas pemphigoid involves the blister formation subepithelially. So if we see there are four variants of pemphigus, that is Pemphigus vulgaris, Pemphigus vegetans, foliaceus and erythematosus. And then other variants are Paraneoplastic pemphigus, Feminian benign pemphigus or Haley disease. Coming to the subepithelial blister formation or pemphigoid lesions, we have cicatricial pemphigoid and bullous pemphigoid. To have a clear idea about the distribution of lesions, let us correlate this with the classification of vesiculobullous lesions according to the anatomic plane. So this is the image which shows the distribution of lesions according to the place where the blister formation happens, whether intraepithelially or subepithelially. So these are the lesions which form subepithelial blister formation, and these are the lesions which involve the intraepithelial blister formation. So in epithelium, let us come from the basalmost layer. So in this basalmost layer, if the disruption of the basement membrane happens and results in formation of blister in that area. So these are the group of lesions which form, for example, lichen planus. So if we see the suprabasal or parabasal, that is above the basal layer, the lowermost part of the spinous layer, Pemphigus vulgaris, is involved. If we see the uppermost part of the spinous layer, generally the frictional blisters or viral blisters are formed in this area. And if we see the granular cell layer, that is above the spinous layer, if the blister formation happens, we can see the involvement of Pemphigus foliaceus and erythematosus. So then coming to the subepidermal or the subepithelial blister formation. Here again, as I told, basement membrane, it is further divided into lamina lucida and lamina densa. So if blister formation happens in the lamina lucida area, bullous pemphigoid, cicatricial pemphigoid, etc. has been involved. And if the blister further forms in a deeper area, epidermolysis bullosa, dystrophica, etc. are involved. So just remember, suprabasal involvement is Pemphigus vulgaris. Supravasal involvement is Pemphigus vulgaris, and the granular cell layer involvement is Pemphigus foliaceus and Pemphigus erythematosus, and the lamina lucida we have bullous pemphigoid and cicatricial pemphigoid. Please remember this location. It is very, very important and frequently asked in the MCQ questions. Pathogenesis of these lesions involve the autoimmune reactions, which is when the immune system produces the autoantibodies which are directed against the body's own cells. Exact etiology of these lesions is obscure, but many predisposing factors like genetic involvement, diet, excess garlic intake, virus like herpes group, drugs, predominantly ACE inhibitors, NSAIDs and anti-inflammatory drugs, miscellaneous factors like pregnancy and pesticide exposure may trigger the onset of these lesions. The general mechanism of blister formation involves when autoantibodies are directed against the antigens, they activate the proteases which act on intercellular junctions of the epithelial cells, and they in turn inhibit the communication between the cells and result in loss of cell-to-cell adhesion, and then this results in production of a split within the epithelium and finally the blister formation. In Pemphigus lesions, the T helper cells recognize these desmosomal epitopes and further causes the B cell activation, which produces the antibody formation. So this antibody formed will activate the proteases, and further the procedure goes on like this, and finally the blister formation happens. The antibody group of IgG is predominant in the pemphigus lesions, but in pemphigoid lesions the Fab region of the antibody will bind to the antigen and destroy them. On the other hand, the Fc region of the antibody activates the complement system when C1 binds to the Fc region of the antibody and then engages the other members of the complement from C2 to C9. Few members of the complement like C3a, C5a act as the chemotactic factors and attract the mast cells, which degranulates and releases interleukin, the tumor necrotizing factor alpha, leukotrienes and cytokines. These further attract the inflammatory cells like neutrophils, eosinophils, macrophages and T cells. So these in turn produces the proteases and follows the same procedure and finally results in the blister formation. Here the antibodies are IgG and even the complement system is included in pemphigoid lesions. The antigens involved in the pemphigus lesions are the desmoglein 1 and desmoglein 3. Whereas in pemphigoid, the antigens are the hemidesmosomes, where it involves the bullous pemphigoid antigen 180, bullous pemphigoid antigen 230 and laminin 332. Coming to the clinical features of pemphigus lesions, among the four variants of pemphigus, Pemphigus vulgaris is the most common type. This occurs in 5th to 6th decades of life with equal gender predilection. This involves both skin and mucous membrane like oral mucosa and genital mucosa. In oral cavity, the symptoms appear as much as 1 year prior to development of skin lesions. The clinical features generally appear as the erythematous itchy areas which develop into flaccid bulla that often ruptures and result in formation of erosions or ulcers which range from few millimeters to several centimeters. In oral cavity, the frequent sites of involvement is tongue, gingiva, buccal mucosa and palate. On skin, this involves scalp, face, axilla and groin. So the patient complains of severe painful erosions and often complaining about discomfort while eating or drinking. Coming to Pemphigus vegetans, this is a variant of Pemphigus vulgaris which involves both skin and mucous membrane like Pemphigus vulgaris. This generally appear as two forms, that is Newman form which develop as bulla and erosions, whereas the second form is resulting in formation of pustules. So that is pus filled raised lesions. So these two types subsequently develop into the vegetative plaques due to the hypertrophic granulation tissue formation at the periphery of the lesions. So the Pemphigus vegetans appears like this. So in the oral cavity, there is a characteristic feature of this Pemphigus vegetans is the presence of cribriform tongue characterized by the gyri and sulci which is seen on dorsum of the tongue. The other two variants of the pemphigus lesions are Pemphigus foliaceus and Pemphigus erythematosus. These two are similar type of lesions because they involve the superficial layers of the epithelium, leaving the underlying epithelium uninvolved. As discussed earlier, these lesions predominantly involve only the skin. Very rarely it affects the oral cavity, but this is like very rare. Coming to Pemphigus foliaceus, this is also known as the superficial pemphigus. So this generally results in formation of a bulla which often dries up and results in formation of masses of flakes or scales. So this is how the Pemphigus foliaceus appears. There will be presence of the masses or scales which is suggestive of exfoliative dermatitis or eczema. And then there are 6 subtypes of this Pemphigus foliaceus which we have to remember. They are Pemphigus erythematosus, Pemphigus herpetiformis, endemic Pemphigus foliaceus, immunoglobulin A Pemphigus foliaceus, paraneoplastic Pemphigus foliaceus and drug-induced Pemphigus foliaceus. So among them, there is one more important feature about this Pemphigus foliaceus which we have to remember is the endemic type of pemphigus, which is also known as the Brazilian pemphigus or Brazilian wildfire or Fogo selvagem. So this has a familial origin which is generally associated with genetic relation, or some studies suggest that this occurs because of an insect bite, that is because of the black fly insect bite could be a risk factor for development of this Fogo selvagem. So this insect bite act through a molecular mimicry in generating the autoimmune reaction which is similar in other pemphigus lesions. So then this is how this Brazilian wildfire appears. And then we have the Pemphigus erythematosus. So this is generally termed as the localized variant of Pemphigus foliaceus, which involves the malar region in formation of a butterfly eruptions on the skin. So this is the butterfly eruptions of the skin are seen in Pemphigus erythematosus. Thus concluding, in pemphigus, different sites of involvement is noted clinically among the 4 variants. That is, Then Pemphigus vulgaris and Pemphigus vegetans, it involves both the skin and the mucous membrane. But in that also, 60% of cases only involve mucosa, and rest of the 40 cases, though it involves skin, but the lesions appear much prior in the oral cavity compared to the skin almost 1 year prior. And coming to the Pemphigus foliaceus, it involves the generalized areas of the skin, whereas Pemphigus erythematosus involves the localized areas of the skin like the butterfly malar rash. This can be explained by the desmoglein compensation theory. So this desmoglein has three subtypes, that is 1, 2 and 3. Among them 1 and 3 are very important here. Now let us see the distribution of these 1 and 3. In skin, desmoglein 1 is very prominent and present over entire epidermis, whereas desmoglein 3 is present only in the parabasal and the suprabasal areas. It is entirely opposite in the oral mucosa, where desmoglein 3 is more prominent and present entire epithelium, whereas desmoglein 1 is present only in the superficial areas. So there is one more characteristic feature of this desmoglein 1 and 3, that is they compensate for the function of each other. If desmoglein 3 is not functioning, desmoglein 1 helps in attaching the cells together. So now let us see in Pemphigus foliaceus. If we see, we have two questions. First one is why it involves only skin and why the blister formation is seen superficially. So let us answer. In Pemphigus foliaceus, the antigen targeted against only desmoglein 1 and no desmoglein 3 involvement is seen. So the first question is why no mucosal lesions are involved. So in mucosa, this desmoglein 3 is present only in the superficial areas, whereas desmoglein 3 is present entire epithelium. So even if 1 is lost, 3 compensates and though helps in attaching the cells together, so no blister formation happens. So the second question is why the superficial areas the blister formation happens. So if we see in the skin, desmoglein 1 is present entire epidermis, whereas this 3 is present in the para and suprabasal. So when 1 is affected, this 3 which is present in the lower areas, that is para suprabasal areas, will help in attaching the cells together. So the loss of the attachment is seen only in the superficial. That is the reason why blister formation is seen in the superficial areas. So now coming to this Pemphigus vulgaris. So again we have two questions. Why only mucosal lesions are present, and the second, why the lesions appear prior in oral cavity and very much later in the skin. So coming to this Pemphigus vulgaris, we have two varieties. One is mucosal dominant and mucocutaneous lesions. If we see in Pemphigus vulgaris, the main antigen is the desmoglein 3. Very later, this desmoglein 1 may be affected. So in mucosal dominant, only 3 is affected and 1 is not affected. So since the question here is why no skin lesions? If 3 is affected but 1 is there in entire epidermis to compensate. So that is the reason why no blisters are formed in the skin. So whereas in mucosal dominant, oral mucosa is affected and the lesion is formed in the para and suprabasal, that is blisters is formed here. The reason is the desmoglein 1 compensates for desmoglein 3 in the superficial areas. So loss of the cells happen only in the deeper. Okay. So now why this lesions occur much prior in the oral cavity? Because desmoglein 1 is affected very much later than desmoglein 3. So when these both are affected, so no desmogleins are present to compensate for the function. So both the skin and the mucosa are involved. Now moving on to the other variants, the paraneoplastic pemphigus. So this paraneoplastic pemphigus is generally associated with the malignancies. So what exactly happens is when the tumor antigens produced by these malignancies evoke an immune response, producing autoantibodies against the self-antigens and result in an autoimmune reaction, finally resulting in the formation of bulla. They involve both the mucous membrane as well as the cutaneous involvement. So mucous membranes like oral cavity as well as the eyes are affected. This in eyes, it results in production of the conjunctival ulcers, and in the oral cavity, the lesions are similar to Stevens-Johnson syndrome. And the mortality rate of this paraneoplastic pemphigus is very high, and almost up to 90% of cases show the death rate. And the commonly associated malignancy is non-Hodgkin's lymphoma, whereas it might also be associated with the other malignancies which are shown in this table. Coming to the pemphigoid lesions, that is cicatricial pemphigoid and bullous pemphigoid, let us discuss by comparing both similarities and dissimilarities between them. So coming to the similarities, both of these lesions are similar to pemphigus clinically, but they are different histopathologically. So both of them produce a thick vesicles or bulla which stay for at least 24 to 48 hours in the oral cavity. But whereas in pemphigus, they are flaccid bulla which immediately rupture. The reason for this is, in this pemphigoid lesions, the subepithelial blister is formed. That means the entire epithelium is intact. So this entire epithelium will form a thick border. So these blisters will stay for at least 24 to 48 hours and later rupture and result in formation of erosions and ulcers. Coming to the dissimilarities, the cicatricial pemphigoid, it commonly affects the mucous membrane compared to the skin. It affects both oral mucosa as well as the ocular mucosa. Whereas the bullous pemphigoid, it predominantly affects the skin and very rarely it affects the oral cavity. So the common sites of involvement in the oral cavity is gingiva. So it has a very peculiar presentation, that is we can see the presence of erythematous areas around along the gingiva, giving an appearance of a chronic desquamative gingivitis. So these erythematous areas will remain for several days and weeks even after the lesions actually heal. So in ocular involvement, they actually cause initial conjunctivitis, which later produces an adhesion between the palpebral and the bullar conjunctiva, which will result in formation of obliteration, and there will be an opacity of corneal, which frequently leads to complete blindness. So these lesions actually heal by formation of scar. Whereas in bullous pemphigoid, the common sites of involvement is limbs and very rarely oral cavity, and in oral cavity they involve gingiva, buccal mucosa, palate, floor of the mouth, but no scarring is actually seen. This is the tabular column showing all the autoantigens involved in the bullous disorders with the clinical signs. Please have a look. Coming to the diagnosis, it is very important to have an early and accurate diagnosis, and this starts as early as from case history taking, where the questions include how did the lesion start, where did the lesion start, whether skin or mucosa, presence or absence of any systemic involvement, followed by thorough clinical examination. For pemphigus type of lesions, look for Nikolsky sign. When you apply the lateral pressure on the normal appearing area next to the vesicle, this results in formation of either new bulla or erosions, and this occurs due to the perivesicular edema, which weakens the normal appearing cells adjacent to the lesion. So second, we look for the Asbo-Hansen sign or indirect Nikolsky sign or bulla extension sign. If you apply pressure from upwards onto the intact blister, the blister will increase in its size. That is, we can see the extension of the blister into the adjacent normal area. And then the Zank smear is one more very simple and rapid technique. So this is carried by collection of the content from intact blister and preparing the smear, often stained with Leishman's or Giemsa stain, where we can identify the presence of Zank cells. So these are nothing but a round keratinocytes with hazy or absent nucleoli, and the nuclear cytoplasmic ratio is increased. There will be presence of a perinuclear halo, that is this pale area around the nucleus known as perinuclear halo. So this occurs due to condensation of the cytoplasm around this area. Following the cytological smear, the next step is biopsy. Obtaining biopsy in patient with vesiculobullous eruptions, several factors should be considered, and obtaining a punch biopsy if the blister is small. Whole blister should be taken along with 3 to 4 mm of the normal skin. It is mandatory to collect uninvolved perilesional skin or the unblistered skin adjacent to the normal blister. So either 2 biopsies are taken or 1 biopsy is divided into 2 specimens, and one should be transported in normal formalin for histopathological examination, and the other should be carried out in a special medium, that is Michael's medium, for further molecular testing. So biopsy should be taken, which is further divided for histopathological findings and the molecular examination, that is direct and indirect immunofluorescence techniques. Histopathological appearance of the Pemphigus vulgaris shows the involvement or the blister formation in the suprabasal areas, leaving the parabasal cells attached to the underlying basement membrane. So this appears as the rows of tombstone. So we can also see the presence of the acantholytic cells, that is the loss of cohesion in the lowermost part of the spinous layer, and these are known as the Zank cells. That is, the acantholytic cells are also known as Zank cells, whereas in Pemphigus foliaceus, the blister formation is seen in the superficial areas in the stratum granulosum, that is above the stratum spinosum, below the stratum granulosum, the involvement of the lesion can be appreciated. Moving on to the histopathological features of the paraneoplastic pemphigus, this has few unique features compared to pemphigus, that is presence of the epidermal necrosis, and also this involves the cleft formation both suprabasally as well as the subbasilar clefting. And the reason for this I'll explain in the further slides. And then we also have the presence of dyskeratotic features all over the epithelium, and predominant amount of lymphocytic infiltration could also be one more characteristic feature of this paraneoplastic pemphigus. Histopathological appearance of the both pemphigoid lesions generally show the presence of subepithelial split. So here and here we can see the presence of subepithelial split. Compared to the cicatricial pemphigoid, bullous pemphigoid has more amount of inflammatory infiltrate in the underlying connective tissue stroma, but that is not a diagnostic feature. Since we have similar histopathological features, further advanced diagnostic technologies like immunofluorescence helps in coming to a diagnosis. So moving on to the immunofluorescence technique. Immunofluorescence is a very valuable adjuvant for clinical and histopathological diagnosis. It acts as a gold standard test. It helps in identifying a particular molecule instead of staining the whole tissue in the histopathological section. So identifying a particular molecule helps in noticing whether this molecule is present or absent, and if it is present, where exactly it is located. So this works on the photoluminescence principle with the help of fluorochromes. Fluorochromes contain an electron. When irradiated with light of a particular wavelength, it achieves an unstable high state. And on returning to the ground state, they emit the light of a longer wavelength, which can be captured and identified under the special microscope, that is fluorescent microscope or ultraviolet light microscope. There are two types of immunofluorescent techniques, that is direct and indirect. In direct immunofluorescence, it is a single step procedure which demonstrates an antibody which is bound to antigen of skin or mucosa. So this is the biopsy specimen collected from the patient which contains antigen. We generally introduce an antibody with the fluorochrome already attached to it. So once the reaction happens, there will be release of a particular light, and this can be visible under the fluorescent microscope or ultraviolet microscope. Coming to indirect immunofluorescence, this is a two-step procedure where the procedure helps in identifying the circulating autoantibodies in the patient's blood, that is patient's serum in particular. So what exactly happens is, we'll collect the patient's blood, and from which the patient's serum antibodies are collected from the patient's serum, and they are directed against a suitable substrate. For example, in Pemphigus vulgaris, the monkey's esophagus. So the reaction happens, antigen and antibody reaction happens. So to this primary antibody of which is collected from the patient's blood, we are directing a secondary antibody with the presence of fluorochrome. So when this secondary antibody goes and binds with the primary antibody, it emits the light which can be visible under the fluorescent microscope. Coming to the findings of immunofluorescence, in Pemphigus vulgaris, we can see the appearance of chicken wire or fishnet pattern because of deposition of IgG antibody across the intercellular components of the epithelium. So coming to paraneoplastic, it involves both suprabasal and also the subbasal cleft formation. So in epithelium, we can see the patchy distribution of IgG with or without C complement, whereas at the dermoepidermal junction, we can see the granular deposition of IgG, C complement and IgM antibodies. So in cicatricial pemphigoid, there will be presence of a shoreline appearance. This is due to the deposition of IgG and C and IgA along the dermoepidermal junction. And in bullous pemphigoid, we can see the linear band of distribution of IgG across the dermoepidermal junction. So both cicatricial pemphigoid and bullous pemphigoid, we can see the appearance of the fluorescence exactly at the dermoepidermal junction. Further, the findings of direct and indirect immunofluorescence are tabulated here. So please have a look. The salt split technique is introduced by Gammon, and the main purpose of this technique is to diagnose the immunological lesions which has similar clinical, histological and immunofluorescence findings. Example, bullous pemphigoid and epidermolysis bullosa acquisita, or bullous pemphigoid and cicatricial pemphigoid. So this technique actually involves the artificial splitting of the skin at the level of lamina lucida by incubating the tissue in 1 molar solution of the sodium chloride for 24 hours. So this is again of two types. One is direct and indirect salt split technique. So generally the results appear as either binding of immunoreactants to either roof or to the floor, or in some cases involvement of both. So what is roof and what is floor? So if we see the epithelium and if we see this underlying basement membrane and think this is the underlying connective tissue stroma. So this basement membrane has the lamina lucida and then, as I told, lamina densa. So there will be a split is caused between the components of the epithelium, that is hemidesmosome, and the lamina lucida. So whatever I am drawing with the red line is the split. So the whatever immunoreactants go and bind to the hemidesmosomal component form the roof. So whatever components go and bind with either the lamina lucida or still deeper lamina densa forms the floor. Moving on to the findings of the salt split technique. Example, the cicatricial pemphigoid. In cicatricial pemphigoid, the antigens are bullous pemphigoid antigen and epiligrin. So when autoantibodies come and bind with bullous pemphigoid antigen 2 or type 17 collagen, the epidermal roof is stained because it is a component of hemidesmosome. Whereas the autoantibodies bind to epiligrin, which is also known as laminin 5, which is a component of lamina lucida, the blister floor is stained. In bullous pemphigoid, the antigens are bullous pemphigoid 1 and bullous pemphigoid 2, and these both are the epithelial or epidermal components. So obviously the staining is seen in the roof of the epithelium. I would like to conclude that it is essential to have an accurate diagnosis to have a good prognosis. The diagnosis of the autoimmune vesicular bullous lesion still remains in dilemma even with advancement of the molecular technology. Many newer techniques like immunoprecipitation, Western blot analysis, ELISA have evolved, but these are very complex, expensive and more time consuming. So now immunofluorescence still remains the gold standard in diagnosing these vesicular bullous lesions. So, I hope further research in these areas should provide an opportunity for the generation of new treatment strategies which will prevent the disease occurrence in susceptible individuals. Before ending my lecture, I would like to solve few MCQ questions and try to apply these concepts in solving these questions. So, the first question. Please don't get scared by seeing such a big questions. Actually, the answer lies in the question itself. If we read properly, we can even answer the question without reading the options. But don't do that. Here, we'll see the question first. So, a 45 years old female developed a recurrent oral lesions and multiple flaccid bulla on the trunk and extremities. A zinc smear showed acantholytic cells and direct immunofluorescence showed intercellular IgG deposits in the epidermis. So, the most probable diagnosis is. So, I'll tell you the points which help to come to a diagnosis. See, a female patient, 4 to 5th decades. Okay. Then we have involvement of both oral as well as the cutaneous lesions. And they also told flaccid bulla, that means bulla are rupturing very fast. That means intraepithelial lesions are involved because subepithelial, they are not flaccid bulla. They stay for at least 24 to 48 hours. So this we have discussed previously. And then zinc smear showed acantholytic cells. And direct immunofluorescence showed intercellular IgG deposits. This means it is an autoimmune disease. And acantholytic cells means disruption in the intercellular desmosomes. So the answer is Pemphigus vulgaris. Okay. So now we try to solve this in a reverse manner by seeing the options. So here we told flaccid bulla, that means intraepithelial. So let us see what are the lesions which are given. So bullous pemphigoid, it is subepithelial lesion. Stevens-Johnson syndrome, again subepithelial blister formation. So here the doubt arises between the herpes simplex infection and your pemphigus. But here they told IgG antibodies, that means it is an autoimmune, whereas this is a virus induced. So the answer is your Pemphigus vulgaris. Coming to the second question, in cicatricial pemphigoid, which antigen is bound to IgG on the epidermal side of salt split technique? Okay, so first when we see this, first let us think what is cicatricial pemphigoid and what antigens are involved. So the antigens involved are bullous pemphigoid antigen 2 and then the laminin. Okay, then try to see what is this salt split technique. What is salt split technique? The manual the splitting of the epithelium from underlying the connective tissue at the hemidesmosome and the lamina lucida junction. Okay, so this is how this happens. The split is like, we'll make the split like this. So here they told bullous pemphigoid antigen 2, that is your transmembrane protein, which is also known as collagen 17. So that will be bind to your hemidesmosome. And the second antigen generally hit by cicatricial pemphigoid is your laminin. So laminin is generally present at the dermal, that is lamina lucida or floor in the salt split technique. So now let us read the question again. In cicatricial pemphigoid, which antigen is bound by IgG antibody on the side of salt split technique? So in the epidermal side, what is the antigen? Bullous pemphigoid 2, which is also known as bullous pemphigoid antigen 180, which is also known as collagen 17. So the options, first option is collagen 17. As I told, it is also known as bullous pemphigoid 2 or bullous pemphigoid antigen 180. And epiligrin, this is nothing but laminin. If they would have asked the dermal side or floor, then this would be the correct option. And the other name for epiligrin is nothing but your laminin 5. And bullous pemphigoid 1 and 2, these two are involved in the bullous pemphigoid lesion. Okay, so the answer is your collagen 17. Oral pathology is very vast subject but also has more weightage in your NEET examination. It is not possible to memorize all the topics in this subject. There are few topics like syndromes where no option is left. But other topics, if you understand and apply the concept in solving the MCQs, the subject appears like much easier. And thank you so much for being with me till the end of the presentation. And if you like my presentation, please like, share and let me know the feedback in the comment section. Thank you.